Hey everyone, it's Caleb here, jumping in for a quick second before we kick off the episode to let you know Aggie was out this week. He was in Denver promoting our Tax 990 product at the Nonprofit Technology Conference there, getting the word out about how easy Tax 990 makes filing Form 990 for nonprofits. We just forgot to mention that in the episode, so that's why he's absent, but he'll be back next week. Anyway, enjoy this episode with Dr. Michael Matthews.
And welcome to another episode of the Bandit Room. My name is Charles. I'm joined here in the studio today by Mr. Caleb.
Hello.
Across the table, we have a guest panelist today, Aubrey.
Hello.
Thanks for joining us.
Thank you.
And our guest today is Dr. Michael Matthews with Winthrop University, the head of healthcare management. Is that it? Chair of healthcare management?
Director of healthcare management. I probably get called so many names by students, so anything will fit.
It's good to have you again. We had you on the last iteration of the Bandit Room a number of years ago, back pre-COVID. So it's a pleasure to have you back on the show.
Yeah, it's great to be back. I appreciate you having me.
Thanks. So let's give a little bit of overview as to who you are. So you're a professor at Winthrop. What have you done before that?
So, to give you kind of the elevator speech, I'm a tenured full professor at Winthrop University, been there since 2005. Had a great run there. Mm-hmm. Love my students. Got a great group of alumni. I'm actually doing a Zoom session with them tomorrow night.
Nice.
We're putting together my students and my alumni working in the field for networking.
Yeah.
Prior to that, I was at Mercer Medical School for 2 years.
Okay.
Taught there in their medical school with mostly medical MPH, Masters in Public Health. We also had MD, MPH, and then I did about 15% of the United States Medical Licensing Exam 1. It's actually based on population health and epidemiology, not necessarily anatomy and all the stuff you think. So I worked with medical students in classes, preparing them for that as well.
Okay.
Prior to that, I was at UAB. I got my PhD there, taught at Alabama a little bit. Yeah. Worked at the VA Medical Center in Washington, D.C. for the CEO at the time before that. And then I was at MUSC working there and getting my master's at night. And then before that, I was in private industry. And then that predates me to college, which I don't want to tell you when I graduate, because that gives away my age. I am not Doogie Howser.
Where'd you grow up?
Newton, North Carolina, Hickory, North Carolina.
Gotcha.
So one of the reasons why we came back to Winthrop, honestly, I had a 6-month-old and a 2-year-old. Yeah. And my wife and I were living in Georgia, no family around. Mm-hmm. And I wanted to get back to the Carolinas. Mm-hmm. That's where I was from. I wanted to raise my kids. I wanted to get someplace and settle down.
Awesome. And how long have you been at Winthrop now?
05, so 17 years.
Yeah.
Wow. 17 years.
Nice.
I hope I'm doing my math right.
Yeah.
Close enough. My PhD's not in math. And along the way, I did get a master's in health administration from MUSC, working during the day, going to school at night. And then 5 years, but I finished my PhD.
So your students right now, are they primarily graduating with healthcare management degrees?
Well, yeah. So I do teach capstone strategy classes for the core in the undergrad and MBA.
For normal business majors.
But we have the only AUPHA certified healthcare management program in the state of South Carolina. Okay. There's 51 nationally. There's probably 115 member organizations. About a little less than half are fully certified.
Gotcha.
And all of them are graduating in healthcare management. I also have a group of minors that major in something else.
So you got into what your students are doing. Right. You'd say it's a pretty wide mix between going into, when I think of like directly in the healthcare field, they're actually working at places like Atrium and actual healthcare companies. But you're saying also in the general business world.
Absolutely. And when I say they're working for PwC, they're maybe in the healthcare division.
Right.
Right. But they're all over: home health, hospice, government work. I've had 2 students intern with the National Institutes of Health in the last 4 years. So they're all over. We got probably close to 100% job placement rate. There's always an outlier or two.
Yeah.
But we have extraordinarily high. Yeah, it is.
These days, especially.
And it's been interesting over COVID. We still were able to get students jobs. Yeah. They were able to get jobs. But it has really transformed.
Yeah, yeah. Well, with the unemployment rate so low, I mean, you think that, these kids are able to get jobs pretty easily once they
are. But one of the biggest crises in healthcare right now is the labor force shortages. more on the scientific clinical side.
Right.
It is driving healthcare companies cost up or broke.
Okay. Interesting. That is obviously a big topic as far as the cost of healthcare.
Yeah.
When you're getting into the issues and things like that, of the healthcare industry in general, there's so many different ways you could slice it, as we were talking about earlier. But one of those is definitely just the enormous cost of it. And I should say, and I think you brought it up last time we spoke, and I agree with you, if this is you, saying that healthcare is expensive because healthcare is expensive.
Yes.
And it almost like it should be expensive in some sense, because they are there to save your life. They are there to, how do you put a value on that?
How do you put a value on a cardiothoracic surgeon going through 12 years of training, postgraduate education?
Right.
Finishing their 4-year degree, going to medical school, then doing another 10, 12 years. I mean, where's the monetary value for that?
Right. Well, they're trying to figure it out, and it's the first invoice they send you. The value.
And there's no easy solution, right?
Yeah.
You hear both political spectrums. Well, if we just did this, or if we just did that, And whenever I hear people give a simplistic answer to a complex question, I can immediately identify their intelligence level on the topic they're talking about. Right?
That makes sense. Anything that's too obvious one way or the other, you're obviously missing something.
They're missing something.
Yeah. That's a good point.
Yeah, and neither side's completely correct. Neither side's completely wrong.
Yeah. Is that what your class is like these days? Are there people always debating these ideas now?
I encourage
it.
I'm still one of the few.
Yeah.
I'm blessed, maybe because I don't know why. Just the students behave pretty well in these.
Yeah.
I hope I'm setting a tone for that, because I challenge my left and I challenge my right. But yeah, there's still a debate. I walked into my colleague, Dr. Joanna Jackson, who's incredible. You need her on here, not me. She's incredible. She's also a nurse and got a PhD in health administration. I walked in, and I think it was the second day of class. I just barge in. We're like that. And the debate was, is healthcare a right or a privilege?
Right, yeah.
And you had 35 students screaming and yelling. And and then I started challenging them.
Yeah.
Like, healthcare's all right. Okay, what's more important? Somebody to have a home or food during the day, or a vaccination shot, or see a doctor? If you're looking at rights, are you prioritizing the most basic needs and assessment, right?
Yeah.
And then somebody goes, no, it's not all right. Now look at them as like, we're the richest country in the world.
Yeah.
We can't provide basic health care? And they're looking at me like, are you bipolar?
Well, that's perfect though. That's what
What's what you're supposed to do.
Like.
You're not supposed to indoctrinate people. You're supposed to challenge
Yeah.
and get creative thinking and critical thinking.
Interesting. So what's the right answer?
When I come up with it, I'll let you know. I wish it were a right.
Yeah.
When you have 28 to 30 million people still without insurance, I think the evidence says it's a privilege.
Yeah.
I'm not saying it should be. I'm just saying
like people are willingly going without insurance, essentially.
Well, either willingly or still lacking access, which is an issue with Obamacare, right?
Yeah, right.
I mean, liberals don't like Obamacare because it didn't go far enough, right?
Yeah.
And conservatives don't like Obamacare for a myriad of reasons, including it has the name Obama,
right?
Which is actually the Affordable Care Act, and that's actually short term for the longer version of the bill, the longer name of the bill. Yeah. So, it's probably going to come to a tiered system, and I think it's moving there.
Yeah.
Right? Medicaid is a tier. Right?
Yeah, it's true. I mean, I guess there's always been
there's
that
a tier.
Yeah.
It has a lot of issues and problems, but it's better than nothing for them.
It's true.
Right? Medicare, certainly a tier. Even in private industry, I used to be on the state of South Carolina insurance plan. My wife works for, I don't want to say the name, but it's a big tech company. Most people in tech would know. My benefits are amazing now.
Yeah.
It's a separate tier.
Oh, wow.
I mean, I could be hiking in Tahiti, compound fracture my leg. We have a 24/7 hotline you can call and get your whole family airlifted out for no cost to a hospital that can take care of it.
Wow.
I'm I'm like, who does that?
Right.
We have to talk to our insurance broker if we have this.
So it's probably going to be tiered.
Yeah.
And I think the tiers will expand. And some people will complain about it, and rightly so.
Yeah.
All of a sudden, I'm getting better health insurance than you are.
Yeah.
Right.
Is that fair?
Yeah. So do you see that as being like the old public option that they talked about?
Yep.
Is like you could get, like, the government's eventually going to be like, we kind of already have it, but not really. It's still, you're mandated to buy private insurance, essentially. But you think it'd be like, you're going to get a public option, but it's not going to be as good as the private options?
Yes.
Yeah.
I think eventually. And by the way, the public option was in the initial iteration of the Affordable Care Act.
Yeah.
And it only got stripped out after the insurance companies told the administration at the time that they would not support it unless they removed. And the insurance companies are so powerful, it doesn't matter if you're Trump, Reagan, Clinton, Obama. If they're not going to support it, it's not going to get passed.
Yeah.
And why wouldn't they support it? Now you're forcing people to buy my insurance.
Exactly. I mean, in some respect, the insurance companies came out the absolute best in that whole situation.
Look at the stocks and insurance companies from 2010 to 2020 before COVID hit.
Yeah, yeah.
Winners.
I mean, I'm sure COVID was a rough year for them, but at the same time, I mean, I don't know. Was it?
No.
Not really, because people stayed inside
People
primarily.
stayed inside. People canceled electives,
Yeah.
and the government reimbursed for a lot of the COVID expenses.
Yeah, that's true. So they're still making out like bandits?
Hospitals got killed.
Yeah.
So as a former hospital administrator, I will tell you, respiratory diseases are low margin. You don't make a lot of money. It's very intense. I make money when I've had a hip replacement. Somebody made a buttload of money off that, right? Interventional cardiology, imaging, neurology. But nobody went in for the interventional cardiology. Everyone needing a hip and knee replacement canceled. And hospitals, even last year, saw the American Hospital Association said about half of the hospitals reported negative profit margins. Now, you get down to the weeds and look at EBITDAs and everything else. There's some gerrymandering in that. But yeah, it's tough. You know, we're very fortunate in this marketplace to have more stability here in Rock Hill and in Charlotte, where they still can run a profitable business. But that's becoming the anomaly.
Yeah.
As much as your hospital bills are.
Yeah, that's wild. Now, in your field, you not only watch this in America, but I assume you're keeping track of healthcare systems throughout the world in some degree. I mean, maybe not the ins and outs, every little detail. But what would you say is the big difference between some of the key differences in the American healthcare system and what the rest of the developed world is doing right now? Obviously, we have a pretty unique system.
Right. The obvious part is we don't have a guaranteed benefit for citizens. Right. Now, I hear people talk about Canadian have socialized medicine. Again, I'm listening to what they say and I'm developing. They do not have socialized medicine. They have a socialized form of insurance. Okay. But I can be a private entity. I can be a for-profit hospital. Now, when the government's your major payer, obviously it's going to be linked when it's your only payer, really.
They have more negotiating power.
Now, Great Britain has an actual government run. It's called NHS, National Health Services. I think that's the acronym. And they're actually government run, right? And your doctors work for the government. And as a hospital administrator, work for the government. Germany has compulsory insurance. Actually, Germany is called the Bismarck system, and it's probably close to Obamacare. All right. So they have a law against for-profit insurance. So they're all non-for-profit. They call them a specific name, but I'll call them a non-for-profit insurance company. There's 20, 30, 40 that you can buy into, and it's compulsory. Now, if you make over, I think the number is 80,000 equivalent U.S. dollars, you can opt out and get private insurance. Again, the tiered system. Yeah. Right? But you still have to pay into it.
Right.
Right? And they're very different. And quite frankly, they're German. They're probably the most efficient with the dollar spent.
Yeah.
We have our problems. Canada has their problems. Great Britain has their problems. I was on a talk show recently, and the commentator made a comment about all the Canadians crossing the border.
Yeah.
And I actually corrected the person. And I said, well, it's actually less than 1%. And I got the eye. And I was like, well, we're just talking facts.
Well, Canada's obviously our closest relative in that department. So there hear a lot of stories about how they have more favorable drug prices. I've heard stories of people, Americans going to Canada to get drugs.
Correct.
We're going over there to get.
We're actually trying to get laws passed to get drugs reimported from Canada into the United States marketplace because we can get it cheaper from Canada than we can the manufacturer here in the United States because the government purchases and negotiates on their behalf. Yeah. So I spent some time working for the VA. When I was at the VA Medical Center, which is a whole nother level of stuff, right? Yeah. And many, many issues. But one of the things we could do is actually we can now legally negotiate for drugs directly. Yeah. And our drug costs were significantly lower than Piedmont, Atrium, or CVS.
Well, you would think so.
Because we could leverage. And we saved a lot of money doing that. But Canada's got its own problems.
Yeah. So what are people, what are the problems with Canada right now? So what are people, is it that if you need a important surgery or something and you want it done quicker, you'd come to America?
Yeah. So if you're dying, having a stroke, you're good. Yeah. If you're you're good. You're good to get care, right? You're done. No, I mean, you'll get really good access, really good care, I should say. Wow.
Really good funeral
system.
I
wonder if we could edit that out. No, I'm just kidding. But if you are, let's say, your knee is in pain. Yeah. You're not dying, but it hurts. You need a CT scan. You need MRI, actually, not a CT. You may wait 4 or 5 months. Now, if you're having a stroke, you'll get it on site. Some of it's cultural. Canadians are culturally different, right? They are willing to accept that. A lot of Americans aren't. I ask my students who are like, "Oh, we want health care. Everyone should have health care." I'm like, "Okay, how much more are you willing to pay in your taxes, and how much longer are you willing to wait to go see your doctor?"
Gotcha.
Right.
Right.
Canadians are very willing. Yeah. Even conservative Canadians. They're like, "I wouldn't. No, of course it's all right." But we're very culturally different for a myriad of reasons.
Yeah. We've talked about Obamacare, ACA a little bit. Could you provide a little bit of a bird's eye view on that right now?
So they really should have called it the expansion of access care. And because that's what it did, right? Yeah. If you think of 3 pillars of health care. Right. This is an academic model. 3 pillars. Cost, right? Quality, and access. Where did Obamacare really affect? Cost on a macro level, I mean, it didn't really affect cost. It drove up some premiums a little bit. Yeah. Certainly if you're paying taxes and you're in a higher tax bracket, right? But it didn't dramatically reduce the cost of overall health care. Right. Unless you're one of the 30 million or 20 million people that have gotten on Obamacare through either expansion or going into the marketplace. Yeah. It's a huge cost savings on a micro level. Quality, sure, they created committees to study quality, right? But didn't really impact it largely. But it did cut the uninsured American rates in half. Yeah. Right? Through a myriad of private marketplaces. We have 40 states now, with North Carolina passing last week the expansion of Medicaid. 40 states have now ACA. That's another 600,000 people in the state of North Carolina that'll access a tier of healthcare system. Yeah. And I can easily explain that tier in common terms if you'd like. Sure. So when you have Medicaid, you have really great coverage for services, but you're very limited in where you can go. Any hospital that meets conditions of participation will take Medicare, Medicaid, not a problem. I might could find one dentist in York County who takes Medicaid.
Oh, wow.
Yeah.
I have a student at a major clinic, runs the clinic, a former student. They cap how many Medicaid patients they see a month because while the services are great, it pays about half for the same provision of service as private insurance. Gotcha. You're running a business. People say, well, that's so wrong. I ask my students, you're selling a car. All right. John over here's got daddy's money. He'll give you $10,000 for it. Paul over here, struggling on student loans, working 3 jobs, they can only pay you $5,000. Who are you going to sell your car to?
All right.
the 10 person with 10,000. You're making a business decision.
Yeah.
So don't judge them when you're doing the same thing,
Mm-hmm.
right? But at the same time, it creates a access barrier to a lot of primary care services for people that are on Medicaid. Is it better than nothing? Absolutely.
Yeah.
Does it cure everything? No.
Not really, because it's still not touching the overall cost of everything. Interesting.
Micro level, it does some good things. Hospitals would prefer somebody to have Medicaid than nothing.
Yeah.
There's a reason why you pay a $3 pill for Tylenol in the emergency room.
Mm-hmm.
It's called cost shifting.
Yeah.
Because my AR is full of people without insurance.
Mm-hmm.
So what do? I pass that on to people who have insurance.
Mm.
So in theory, the fewer people coming in without insurance, the fewer cost shifting it goes to those with insurance. Not going to decrease, but probably slow the rate of increase over time. We're getting micro level right now.
That was the big bet with the ACA, is that we thought getting more people on insurance, that will help, spread the cost around. The people with insurance, the several people with insurance aren't going to be shuttling all of the
the term is called risk pooling.
Yeah.
Right? You want to increase the risk pool size.
Right.
Then you can distribute the risk of medical loss, which is what insurance companies call a payout to a provider.
Mm-hmm.
And instead of, if I only have 10 people in my pool and one gets sick, the 9 have to cover it.
Yeah.
If I have 10,000 and 100 get sick, I still got 9,900 to spread the risk. And it's done a decent job. It's done a good job at getting more access. It didn't cure it, but it's treating symptoms.
It's treating the symptoms. Last time we spoke, it was at the point where they had just kind of taken some teeth out of the ACA when they took away the individual mandate or the penalty of the individual mandate.
Yeah.
That's still the same as it has been. Even through the pandemic, there's no changes. You don't have to get insurance anymore if you don't want to.
Right. And technically, I think they may have actually just made the penalty $0. I don't know if they ever actually erased it.
I think that's all they did. Yeah. I think you're right.
It's still there, but the penalty's nothing.
Yeah.
Good old government at work.
Yeah.
I don't think it's impacted as much as people thought.
Yeah. Because at the end of the day, people still want to get insurance.
People who can afford to purchase into the marketplace are most likely still going to try and purchase into the marketplace.
Yeah.
The key is the subsidy stays, right?
Right.
And as long as the subsidy's there,
gotcha.
It incentivizes. They're taking money from people over here and giving it to people over here. But at least the outcome is they're getting a decent insurance plan. Yeah. More people with insurance is generally better than less people with insurance, regardless of the insurance that they have.
Yeah. So last time you had like a list of like some of the great things that ACA did that most people would agree with. Talking about the $1 million cap. People don't remember that anymore.
Yeah. So it used to be a cap. Insurance plans had a $1 or $2 million cap. I think our state plan is at $2 million. I have a colleague whose wife has to take $125,000 worth of drugs to keep her cancer at bay every month. I mean, you beat your cap. After you meet your cap, you're uninsurable, right? I have plenty of students who are 23 and 24 still on their parents' insurance plan. Yeah. That's a nominal cost on a grand market. 24-year-olds are not costly to insure. Yeah. You're mostly healthy. The largest reason you die at that age is accident. Some of those accidents lead to high cost. Unfortunately, a lot of those accidents don't lead to many cost because once you get to the hospital, you're DOA, right? Or there's little accidents that don't cost a lot. So they're cheap to insure, and that's great. My daughter is going to be in grad school in a year, starting grad school her senior year, but we'd had to kick her off her plan in a year and a half. She had to get her own plan or go uninsured. Yep. I actually was uninsured in college for 4 months. Yep. Right? Yep. I rolled the dice. I took a little longer to get through college. Different story. I went to App State. That might explain a couple things. So didn't want to leave Boone. Yeah. And I got hit with a outpatient bill that I had to pay out of pocket for about $1,500.
Gotcha. Wow.
It's a bad risk.
Yeah, that's true.
So there's still some good things, right?
Right.
But it's not all good.
Yeah.
Those who hate it it's not as bad. Those who love it, it's not as good. It's somewhere in between.
Somewhere in the middle.
And it depends on where you sit on the pendulum.
Do you think ACA is going to stick around for a while at this point because it's kind of just ingrained as the current system? Or
Yeah, I mean, when Republicans tried to repeal Obamacare, the best thing that happened to them is John McCain going out and giving the thumbs down because the rural, this is just statistics, the rural lower income white folks who are on Medicaid because of Obamacare would have lost it. And those major voters would have all of a sudden realized that the party they voted for just took away their health insurance.
Right.
Specifically Kentucky and some of the southern states that have adopted the Medicaid expansion before the election cycles. It would have been a tough thing for them.
Because on the left side, you see the only other alternative really that's being talked about is like a universal health care. But on the right, I don't really see a plan on the right. Like, I don't know. What do they want to do? Just completely go back to just no government intervention at all and all private?
Yeah, repeal and replace was more just kind of repeal and figure it out.
Right. It was repeal and replace with something much better.
Well, yeah,
I believe that was the official.
Repeal it and go back to what we had.
Yeah, it'll be better and cheaper.
Right. There is no consolidated plans. There's some push towards like things like medical saves accounts, high deductible plans, which are actually good for a certain marketplace. Right. And we do need to get, in my opinion, more association with our own cost and our own pocketbook.
Yeah.
Right now, we are completely insensitive to our healthcare decisions because somebody else pays for it. I always say, imagine you had grocery store insurance.
Yep.
And your grocery store insurance would pay 80%. Would that change the way you shopped?
Right.
Are you buying Milwaukee's Best at that time?
Right.
Are you buying the cheap steak?
Yep.
Right. It does influence us when we have another person paying for the majority, how we utilize healthcare, and that does drive up utilization and healthcare costs.
That's absolutely true. I agree with that. You don't feel every time you go to the doctor, you're not exactly feeling like a transaction.
You don't even know what their actual cost is, and you don't care.
Not until later.
You wouldn't go to dinner like that, would you?
No, right. Anytime there's like a degree of separation like that sort of gives the person that you're buying from the power to price things however they can price them.
Yep.
So you could see why, healthcare has increased higher than inflation. I think the past
it's called the Medical Consumer Price Index.
Yeah.
MCPI. It's an alt version of CPI. It's not a great metrics.
Yeah.
But it's one they use. But it is far outpaced.
Yeah. To me, that seems like that's an industry that's ripe for disruption.
Yes.
Where do you see the biggest potential areas for disruption in the space?
Artificial intelligence replacing professional jobs. We've never really had a technology replace professional jobs.
Yeah.
It was workers. I always hope I see my doctor, but I could really see a doctor managing an AI list of patients the AI saw. Right. Kind of like they manage a physician assistant or nurse practitioner now.
Yeah.
I see in accounting, I see AI as a huge disruptor.
That's true.
To anybody professional. There's a company in South Carolina, a Winthrop grad named Scott Middleton owns South Carolina House Calls. They actually provide primary care in your home. It is not home health. It is a doctor going in, doing your physical, managing your diabetes, or a PA or nurse, and they will drive to any of the counties in the state. They're doing probably 50,000 visits. Wow. That would roughly make them probably one of the top 5 providers of healthcare, of primary care in the country. That's a huge disruption.
Yeah.
Express Tax Exempt is now tax990.com. We changed our name to make it even easier to recognize us, but everything you know and love about Express Tax Exempt is still here. Tax990.com still provides you with easy Form 990 filing, free schedules, great customer support, and much more. Learn more at tax990.com.
And we're back from the break. We're enjoying a little glass of the Burning Chair today from, it's an O'Darby's store pick.
It's burning.
Quite enjoyable.
Is it burning?
So one of my favorite restaurants, I live up in Ballantyne, and we have a Midwood Smokehouse.
Yeah.
And you can go there, and you can actually get a flight of bourbons.
Mm-hmm.
Oh.
So I'll put in 4 different bourbons in a little shot glass, and you just basically get those and get a water, and that's your dinner.
Yeah.
With dinner. But you get to try
Liquid
4
dinner.
different ones
Yeah.
for like $22.
Right.
So, you can venture out on some of the ones. They probably have 20 different bourbons you can choose from there.
Yeah.
Goes well with barbecue.
Yeah, I bet,
for
I
sure.
bet.
So you didn't answer the question about ACA. Is it gonna stick around, or
Trying to divert.
you think? Yeah. Now that we got a little bourbon in you, maybe you'll answer.
I don't think it will go away. I really don't. I think it'll change. Our healthcare, it's always iterative, slow change, right? 1929, Blue Cross introduced hospital insurance for teachers in Dallas, Texas. They could get hospital insurance for the whopping cost of a year. How much? Guess.
The 20s.
1929. What would it cost to insure a teacher for hospital care for the year?
It's gonna be like $5.
Dude, you nailed it.
Yeah, really?
What?
$5
$5
for a year?
for you. Now, what could be done in a hospital at the time, right?
Yeah.
What technology existed? I mean, we weren't manufacturing penicillin in 1929, right? I mean, it just, there's not much going on.
It was
insurance
I'm
became,
afraid she's dying.
Just go in and hope for the best.
and then, you didn't certainly have satellite, cable TV, private rooms and all that, right? 4 people to a room. You took your own sheets and linens.
You had
And
to
your
bring
family
your own
brought you food, right? We didn't have concierge service like we have today.
Right.
The 1939, the insurance companies did the same thing for the physician side. One was called Blue Cross, the other Blue Shield. Medicare in the 60s passed. Medicaid was a throw-in, last minute. Why did it pass? Because 1 out of every 2 people that were over 65 did not have health insurance.
Yeah.
Because you had private insurance and you retired. And by the way, private insurance grew from about 10% of the market in 1940, less than 10%, to over half people being insured in the 1950s. Simply because World War II happened, and when they put wage holds, you could not increase salaries and so forth. They left benefits alone. So if I couldn't pay you more, I could start offering you health insurance. So we have a healthcare system that came out of mistakes and one-offs.
Yeah, it's a weird system.
Classic.
I mean,
Right?
that's interesting.
And it evolved.
Yeah.
Health insurance wasn't even a deduction for businesses until 1954.
Wow.
Yeah.
Right? And then it kept growing. And then Medicare, because mom, if you had grandma, granddad,
Right.
over 65, one of them didn't have health insurance. The marketplace is the government comes in theoretically where the marketplace doesn't work for the masses, right? The insurance marketplaces work for young, healthy people. They don't work for older, unhealthy people because they're too daggum expensive. So the private and for-profit insurance companies only want to insure the healthy people.
Right.
They will throw off the unhealthy people, aka old or low income, and low income has far social determinants of health dictate that, and they have far more healthcare expenses and worse outcomes, right? And it's older people. Throw that to the government. Let us take this healthy people, and then the next iteration and the next iteration. So yes, there will be more iterations to the Affordable Care Act. If I could look out in the future in 10 years and tell you what those were, I wouldn't worry about my retirement plan. You can see it going one way or other.
Yeah.
Maybe there's a political shakeout next election and everything gets repealed again, or people are going to continue to expand like we have 40 states now with Medicaid expansion.
Right.
And you can see us filling holes like we've always done,
Right.
whether it's Medicare, original Medicaid, we're filling a hole, and we'll try and fill another hole and insure some more people who are uninsured.
Yeah. That seems like the most likely outcome. At least it just kind of continues as it is.
There's too much money in healthcare to completely change it. I mean,
Well, for sure.
people make
For
too
sure.
much money.
Yeah.
Politicians get paid too much money.
Yeah. The only way I could see it change is if there's a very compelling national candidate that has a very defined plan that's easy to understand.
Yeah.
And that just hasn't happened recently.
No, it has not.
Not really.
No, it hasn't. All right, even the Democrats,
Yeah.
right? They're the Ted Kennedys of the world used to run on a specific platform of national insurance.
Yeah.
Then the Clintons and Obamas of the world were let's fill in some gaps.
Right.
And then the other political party just says let's demonize what they're doing and not really do anything.
Right. Right.
And both have positives and negatives.
How did COVID change what you do?
Well, I had to teach online for a while.
Yeah.
That
Yeah.
stunk.
Yeah.
It actually did change. So in addition to my other roles, I mentioned we're the only AUPHA certified program. That's our accrediting agency, right? So I'm actually co-chair of undergraduate programs in the United States, Canada, and Asia. That sounds fancy. We have 2 programs in Asia, but I get to claim the whole continent. We had to amend the way we accept the criteria for internships. Used to have to required an internship on site, no caveats. Then all of a sudden, programs were like in California and New York are like, nobody's taking interns in 2021, 22. Nobody wants a college student walking into their hospital, bringing COVID in, right? So we've now gone to a lot of remote internships.
Yeah.
We even now have certain caveats. Colleges can define what can replace an internship, right? And that's actually kind of mimics the job place, a lot more remote and so forth. So it is it's hurt higher education financially terribly. I like to say COVID exposed a lot of weak business models.
Yeah, for sure.
That's what Charles says pretty much every time we talk about COVID.
If your business model wasn't working before, it killed it with COVID.
And let's be honest, right? I work in an industry that still is built on a model for the industrial age, not the technology age.
Yeah.
Right. So where do you see college in 10 years? I mean,
Seriously,
that question as well.
I mean, how much has college changed since 1950 in the classes that we require people to
I should
take?
ask you, how has it changed since last year with the introduction of OpenAI and ChatGPT?
Yeah. We're trying to figure that out. So, fortunately for me, in healthcare, I give very specific exams, and I give a lot of specific case-based stuff.
Yeah.
That makes it a lot harder for the current versions to pick up on. But if you ask the kid to go out and do a paper on the history of United States healthcare, they could be done in 5 minutes on chat.
Right.
But if I ask a kid now, how did the inclusion of this act at this time with this administration impact X, Y, and Z, and I throw in more variables, then AI still scatters.
Right.
I mean,
But it's a real threat, and we're just now trying to figure it out.
Yeah. That's wild. It's pretty close. I saw a meme that was like 10 years in the future and your doctor got their degree by using ChatGPT. And so, like, you're screwed in 10 years as a patient.
Well, we always say in the healthcare world, the physicians, the real doctors,
Yeah.
get tired of people coming in with their doctorate in Google and
Yeah.
telling them, the doctor, what's wrong with them and how to treat them.
Yeah.
Because they did a 10-minute search on Google.
Right. But then the doctor goes in the other room and Googles it.
Yeah.
Awesome. I think we have a little game for you.
Yeah.
Caleb, do you want to explain what this game is?
All right.
If I get it wrong, do I have to do a shot every time?
You do. Yeah,
Yes.
that's the way it works.
So this game is called Biomega RX. I think we picked drug names and medical procedures.
All right,
Some
you do
of them-
realize my PhD's in health administration, not
No, I know.
pharmacology.
I know, but it's
Which
still
is
it's just
why
fun.
it's
It's just
okay.
fun.
I don't think I need
some
my
of them are real.
All right.
Some of them are fake. Your job is to figure out which ones are which.
And we used the aforementioned ChatGPT to come up with the fake names.
Yes, we did. Okay, so
ChatGPT's it's going to be smarter than me. but-
Yeah.
All right.
All right, so medical procedures. Here's the first one. We'll try and pronounce this. Osteoodonto oh boy.
All right.
Keratoprosthetic.
So basically, osteo is bone, odonto is going to be mouth, keratoprosis is going to replace
It
a
is a
portion,
portion of the tooth along the
support.
bone.
All right. The words are actually Latin-based words, which are medical terms. Most of
Right.
medical terminology is actually did take medical term classes. I will say that's true just based on that.
You're correct. This is
So
a real one.
Okay.
This is real. And
Ding ding, one on the board for you.
One on the board, one
All
on
right,
the
I
board.
quit.
Nephroretroviral theraplatting.
Good job.
Well, retroviral sounds smart. Nephro. All right. So that's nephrology.
There's a little less Latin in this one.
Yeah, there is a little less Latin. If it were real, you're dealing with the renal system. With the retroviral theraplatting, I'm going to say no.
Correct
Whoa.
again. Correct again.
You're beating the system. He can spot the
Those
AI.
classes I took in medical term
Yeah.
10 years ago.
Cardiohepatic angiography.
Angiography.
That's good.
I know an angiography is real. I know cardio real, so I'll say yes.
No, that one's
Damn.
fake too.
Dang. Oops. I can say damn, right?
You can,
All right.
you can.
Say what-
2 out of 3. That's pretty good though.
Yeah.
And then we'll get one
I was
more,
at
which is
100%. Now I'm at
75. That's okay. It's okay. And then we have 3 more drug names, and that's it.
oh, no, God, no.
Sniffle Rex.
I'm going to say no. If I get
Greg,
that wrong,
okay,
I can
that's
live with
fake.
it. But if I said yes and it was fake, I could not live with that.
Yeah, Sniffle Rex is fake. Vinblastine.
I've got a friend who runs a company that actually names probably 20% of the drugs.
Really?
Yeah.
So how are they
A
coming up
branded
with
company. The key is,
Just
can you trademark it? That's
Oh.
it. That's all that matters. You
That's
don't
it.
have to mean
That makes
anything.
sense.
You just
So
have
the,
to be
the
able to
weirder the
trademark
better
it.
in that respect.
That's
Yeah.
it. And they make a lot of money doing that. I'm going to say no because the blasting just doesn't sound right.
Can't
That
hear
one
it.
is. That one is.
Gosh.
You can't hear the jingle. Vin,
Moxifloxacin. There's a whole bunch of
Moxifloxacin.
Moxifloxacin.
So the CIN will actually dictate what kind of drug this is at the end. So it treats bacterial infection, right?
Okay.
On CINs.
Okay.
Amoxicillin, anything in the ends. It also means
Yeah, yeah.
it is probably a derivative of mold. So anybody who's allergic to mold, penicillin, if you're allergic to that, you have a mold allergy. Amoxicillin, you have to take a different classification of drugs. I'm just trying to pass time because I have no clue. Trying to sound smart before I get this wrong.
That's pretty good. I mean, you sound smart.
But
so.
that was factually true. That's
Yeah,
what I'm
that's what I'm
saying.
saying.
I can even give you the history of Fleming in the 20s and how he actually found that mold killed bacteria by accident in cornfields when mold got into a petri dish in the 1920s, which later brought about the revolution of penicillin, which we sat on for 15 years until we sent soldiers to war and more soldiers were dying from infections than combat wounds. And the government looks around and goes, how do we fix this?
Yeah.
Oh, wait a minute. We figured this out 15 years ago, but in the 30s, during the Great Depression, we had no money.
Yeah.
So World War II is the first war ever where people died more from the infections than the war injury itself. I'm going to go false.
That's a good.
That one is
Dang it.
also
Oh, it's
real.
real.
That one is also
Well,
real.
I had a good
Oh,
15.
you had a good run.
I had a good 30, 40 seconds with
had
your
to-
listeners going, wow. But that was a true story, by the way.
Yeah, it was an interesting
Alexander Fleming.
Yeah.
Excuse me.
Oh no, are we done? Is that
That
it?
was it. That was
That
it.
was it. Okay. All right. Well,
Yeah, just a quick one this time.
a
but-
pretty good run though, I'll say.
So at
it's
least
not
I
bad.
got to say what I knew
Yeah.
while staying away from things I have no idea about.
Yeah, you sounded smart no
You
matter what
sounded
it
very.
was.
Well, I should
smart.
have, with the Ixon in it, I should have gone with it. Just it fits the Latin,
Right. You're too cynical.
Yeah, it does. It does sound funny.
Moxie
mostly
sounds
Latin, a
fake,
little bit of
though.
Greek, and then it's named after people, like Alzheimer's.
Oh yeah.
You know, it's named after an actual person, right? So anyway.
Yeah. No,
All right,
that's
time
good.
for a
That's
shot. I wound up getting a 50. I flunked the class. And the professor's a bad student.
No. We're rude. We shouldn't have done this.
If I had a pharmacist with me, I'd bet you I'd have made that.
Yeah.
Made 100.
Yeah.
It was this or quiz you about the price of having a certain kind of procedure.
Oh yeah.
Oh, yeah, we were
Price
gonna
is
try to-
Right.
That was we don't know how to
We're gonna try to
look
come
that
up
up.
with a price is right for medical
The
stuff.
problem is the price that's quoted is never the price that's paid, right?
Right. Yeah, that's half
and
the
that's-
issue.
So I had a hip replacement.
Yeah.
The bill was $100,000.
Right. But what did the insurance pay?
Insurance paid $30,000, and the contractual allowance wrote off
Yeah.
$69,000, and I paid $1,000 out of pocket or something like that. Right.
Right.
So what was the cost? I guess the insurance, whatever the insurance.
The
paid.
insurance
Yeah.
reimbursement was a little over $30,000
Yeah.
for it. About 10 years ago.
Yeah.
Yeah. So you'll find that labs, you may get a charge for 70, but insurance may bill it at 10.
Right.
Problem is, if you don't have insurance,
Yeah. You got the original bill.
you get the original bill.
Yep.
Yeah.
So those who have the least are getting taken advantage of
Yeah.
the most.
But you can't
because they don't have an insurance company
And you can't negotiate. Yep.
on their behalf.
Wow.
And rarely do hospitals set prices, insurance set prices.
Yeah. Oh,
It's a negotiation, but
right.
I had the CEO of a local hospital, Mark, and did a great job with students, and he made a comment. He goes, we're told what we're reimbursed
Yeah.
from insurance.
They just tell you this is what we're paying.
And
for this.
certainly you don't negotiate
Yeah.
with Medicare,
Yeah.
with the government.
Right.
You know?
Mm.
But the first number the hospital's coming up with, right? As far as like
Yeah,
what they
yeah,
said, they said we think this is
So
100,000.
it comes off a document called a charge master. All right. And it's based on a UCR, usual, customary, and reasonable. So what one hospital does is looks around and goes, well, they people get paid 60,000, but because we're this company and we have a better brand, we're going to say 70,000.
Gotcha.
It has nothing to do with the actual productivity or efficiency going into the service.
Right.
Has nothing to do with the quality of the service.
Yeah.
It's a house episode called 9 to 5, season 4, season 5.
Yeah.
And all it is the hospital insurance company using their names and brands to leverage to negotiate a price
Yep.
for a myriad of services. That's all it is.
You touched on a little bit earlier that private insurance was not the norm until what, the 50s?
50s, yeah.
So weird.
Insurance,
So-
period, wasn't the norm until the 40s
then,
and 50s.
people simply paid for their health care.
Yeah.
Okay.
Yeah.
That's
The
weird.
price
Why
was
would they
lower?
do that? Why would we pay for our health care?
Well, I mean, again,
So then the prices went
what
too high.
were they paying for at the time?
Right. Yeah.
The drugs
Right.
didn't really exist much.
Back in the day.
You had X-ray, but you know
Yep.
you weren't getting MRIs and CT scans. You weren't having these surgical robotic arms going into you like a Da Vinci robot.
Yeah.
I mean,
Right.
what were you getting at the time? Really, the argument should be because people had insurance, it accelerated technology. Because now there's a way for it to get reimbursed.
So would you say we have a better system because of that? Or do you think if we had continued with a model of you have to pay for your health care, and if you don't have money, you're just going to go bankrupt?
It would be
I guess?
different. I don't want to say better or worse. I'll say different.
Yeah.
Clearly, I think.
Do you
it's
think it
better.
advanced? Do you think you said it?
It's advanced.
You think it furthered the technological advancement of the field?
Oh, it's unequivocally. If for-profit companies can't get reimbursed, then they don't develop.
Right.
Whether it's drugs or anything else, they have to be able to make money off of it.
Yeah.
And the likelihood of you and me paying them out of pocket,
Right.
where they can make enough money, as opposed to have a large insurance or third-party institution. So it has proliferated and accelerated technology advancement. It's also there's a book I read by Peter Senge, and he talked about these models, and basically it's like one of the models is your greatest failures lead to your greatest successes,
Yeah.
and your greatest successes lead to your greatest failures.
Yeah.
It's also kind of the Icarus thing, you know, the Greek
Right.
person who flew to the sun
Yeah.
and got too
Right.
close, and right.
Yeah.
Well, we're on the downslope of that.
Mm.
Right, all this technology is getting so expensive. It's now hurting access, hurting cost, and hurting the system, and hurting citizens.
That's wild, though. You'd think, though, that a lot of technological innovations create deflation. To buy a computer or TV,
airbags,
you know,
TV.
you
name
buy
it.
that stuff today, you can buy it no problem. Back in the day, that was like serious money you're
Right.
shelling out for those kind of items. So why is that not happening in healthcare when we're having these sort of
Wow.
increases in technology, but not the
I'm going to go back to what I said before. There's no simple answer. I can beat around the bush a little bit,
Yeah.
but I can't. You know,
Yeah.
I can't knock the thing down. God, well, if you want to look at it from one viewpoint, we are highly regulated.
yeah.
Right. Regulations are generally written because somebody did something really bad, and regulations are written for the one or two idiots to not do that again, not for the majority, but that's how laws are written.
Gotcha.
Right.
So a highly regulated industry
It
typically yields a higher cost involved in that industry.
Yeah.
Whereas a non-regulated industry, it breeds more competition and people can
to get a
outperform each
simple
other.
drug. I mean, you got to think. One of the jobs at one of the health systems I worked at was pharmaceutical research.
Yeah.
We did FDA level 3 and 4 level studies, right? So you have 4 different levels. Level 1, you inject a mouse with a drug, and did you kill it? No. All right, let's go to level 2, right? So you inject it in 1 or 2 people, and let's say, hey, you had COVID, and we tried this out. A, it didn't kill you, and B, COVID got better. Then we do a level 3, and that's completely randomized.
Yeah.
So from infancy to level 1 to level 2 to level 3 is a 10-year process and $120 million process. And an acceptable failure rate is 96, 97%. So the 2 or 3% that you get through, you're not just covering the cost of that. You're covering the cost of the 95% failures, reinvestment in the future. And oh, by the way, the drug company over there is going to come out with a drug better than this in 2 years. So I got to price it really high to return my cost. And then I got these shareholders over here who are crying because the stock price hadn't gone up 25% this year. So now I got to invest in them. And all of those confluences affect and drug prices are what, 10, 12% of all US dollars spent. So that's a small part.
Yeah.
You know?
Interesting.
So that's just one carve out.
Yeah.
What do you think?
People.
I've talked all the time.
Do you have any questions?
I have a situation. So I'm 29 and my husband is 29 and he has brain cancer.
Oh my God, I'm so sorry.
No, it's okay. But
wow, hold on.
So my take on insurance is very different than what it was a year and a half ago.
Yeah, when you need it, you see it differently.
She's not the average 20-something that doesn't care.
Right. So it's interesting too because we are still some of the lucky ones. Like, yes, we now have thousands of dollars in medical debt, but we had good insurance and we had an emergency fund and we were both working, but it's terminal cancer. So none of those fees are going away and they're just going to accrue even though we still pay for the insurance. So I'm like, what happens to the middle ground people who aren't getting the lower grade insurance or the high private because they work for a good company? You just fall into like this. Well, it's not bad. It's not as bad as it could be, but it certainly could be better.
So that person on Medicaid and Medicare would actually have the same access as long as they could access a provider. So like the Medicaid person at the hospital will get everything. They just have to find a doctor in a private office who will take Medicaid. That's the problem. Medicare taken, private insurance taken.
Yeah.
God, I'm so sorry.
No,
geez.
It's a real Debbie Downer whenever I have to bring it into a conversation, but it applies here because
it's a legitimate application of it, and you are going to get bills. You're going to get bills for a long time, right?
Time, forever.
You know, you get a lab bill from here and that bill from here and that bill. So here's my recommendation: never pay a bill until you get an itemized bill, because now it's changed with medical records, but there was a Harvard Business Review study about 20 years ago. Over 20% of all medical bills had mistakes, basically overcharging or upcoding. Bundling. I've actually saved $10,000 roughly since I moved here. I keep a list. Yeah, I'm that PhD dude. Yeah.
Need to take a lesson under you.
Hip replacement and hip revision. Daughters had 4 concussions, broken bones with kids playing sports. So lots of things. Wife's had some health issues. Lots of things. I'll always ask for an itemized bill first because they just send you a bill, right? I break it down. So I actually know a little bit about medical coding. So when I see these CPT codes, current procedural terminology from the HICCUPs, which is an acronym, I didn't hiccup, or the ICD-9, ICD-10 codes from the hospitals. So you might get a code and it says a lab, and you ask for medical detail. It'll say it's bundled. Well, that's not good enough. I call them what was bundled in it because I see a bill for a bundle and I see individual bills for individual labs on the same day. And it turns out some of the individual labs were also part of the bundle.
So they're double charging for that.
Yeah. Double charging. Upcoding happens. I'll give you a simple upcoding scenario. Michael walks in and sees a primary care doctor. My primary care would never do this. Primary care doctor for a simple 10, 15-minute visit. He gets billed $60. But if they slightly change the code, it can make it an extended visit. And now he gets $100. There's a financial incentive to do that.
Yeah.
Because it's hard to catch. Yeah. Right? So I would get itemized receipts from everyone. They won't send it unless you request it. They're required to once you request it.
Okay. Just with the ACA forms, they're a pain, I think, or burden on businesses that have to report it.
Of course, it's a government document.
And the fines for even being late are just absolutely insane. So I don't know. Like, I get what they're trying to do, but just the fact if you're like behind or late, you can get fined for every single one of your employees for being like a day late.
Yeah.
And it'll put you out of business.
Yeah.
It's crazy.
Yeah.
It's the one part of ACA that still has teeth.
It's crazy. Yeah.
And that's where y'all come in and help,
That's
right?
that's where we
That-
help.
yeah.
Yep,
So
that's
ACA has been
wise.
good for a lot of businesses.
That's right.
Yeah.
It's been all right. It's been all right for us.
That is true.
I mean, and it's true. It's been just winners and losers, right? I mean, there were losers in ACA. Okay,
Yeah.
I had two friends who had kind of crappy, cheap health insurance plans that maybe had limited coverage. If you had cancer, you only had $100,000 worth. That doesn't last long, right? But he took a bet. He went. So anyway, when ACA passed, it required 10 basic provisions of services: maternal child well health, one of them; mental health, one of them. Not only mental health, but mental health parity. And we can come back to that if we had time. If not, that's fine. But he didn't have all 10 provisions. So that promise, if you like your health insurance company,
Right.
320 now 340 million Americans, right?
Right.
3 or 4 million people lost it, which meant the rest of America didn't.
Right.
But for those 3 million people who now had to go buy a marketplace plan at 2 to 3 times the cost, they're pissed, right?
Yeah.
Now, who knows? It could have benefited them. They could have
Right.
gotten cancer, which they had limited provisional coverage, or But so there were people who lost, but there are also far more who gained.
Yeah.
It depends on what you consider good.
Yeah.
Good news is he can get $20 billion of healthcare coverage and still keep insurance to help him as he progresses, right? Where you'd be cut off at 1 or 2,
Yeah.
which goes fast.
Yeah.
Of course, $1 million doesn't go as far as it used to.
No.
That's true.
That's the issue.
No.
Could be 1 year. Wild. All
And
right, should
one
we
other
move on?
area is mental health parity.
Yeah. So what is
Yeah.
Oh,
that?
yeah.
Some? All right. So prior to mental health parity clause of Obamacare, mental health could be treated different by an insurance company. So you have, how you have like dental insurance and vision. They're always separate,
Right.
right? Because they have this term moral hazard, right? If you have dental insurance, you're more likely to go to a dentist.
Okay.
All right. If you have vision insurance, you're more likely to get you a new pair of these every year.
Right.
All right. If I have health insurance, I'm not more likely to run out in front of a Mack truck because I get covered. I'm not more likely to try and get cancer, and I'm not more likely to try and have a heart attack.
Right.
Yeah.
Right? So there's no hazard. But with mental health, there's a huge moral hazard. If you know it's covered and you have it covered, you're more likely to use it, which is good. Moral hazard sounds like a negative term. Economically, it kind of is, but the reality is we want that parity. So a lot of insurance plans said, all right, you're covered 80% for everything except mental health, 50%. The parity now requires your insurance plans, whether they charge everything at 50% copay or 50% coinsurance or 20, they have to treat mental health the same. And as we've seen in the last decade, we literally have a pandemic, an endemic, if not a pandemic, of mental health. It's real. It's real on my campus. I see it weekly,
Yeah.
right? It needs to be treated like it's diabetes. It's a disease pathology. It can be treated. We got to kill this stereotype. And Obamacare did require that of insurance companies. And it's something they don't get credit for.
Yeah. That's interesting.
And it should. And it does drive up cost, right?
Yeah.
Because now the insurance companies know they're going to have to pay more out in mental health. So it's going to drive up premiums.
Yeah.
It's a downside. It's a downstream to everything.
Yeah.
That's interesting.
I have talked
Anything.
way longer. Guys, you're going to have to edit
No,
the
you've
hell out
gone
of
No,
it.
good.
it's a
You're good.
very,
I
very
mean, you're like,
It's all good.
shut this guy up.
informational
no.
conversation.
You're
Very.
great. So we should
Yeah.
we should probably move to the lightning round while
Yeah.
we still have you.
Oh, my God. We're not done yet?
Hey.
How many
So
shots
close.
are you going to have me take before we get out of here? You're driving me home, young lady. All right. Let's
Here comes the lightning round. Or speed round. Faster round. Anyway, we're going to ask the guest a bunch of quicker questions. Here we go.
First off, what is something that you would say you spend way too much money on?
Going out to eat.
Okay.
Yeah, who doesn't? Yeah.
Right.
Food and drink. Get lazy.
Next question. When you were growing up, what was your dream job? And is any of that still true?
Oh, well, I don't know if it's a job, but my dream was to play basketball for Dean Smith at the University of North Carolina. My dad
Okay.
actually played freshman basketball for Dean Smith
Oh,
in
cool.
1958.
Wow.
Nice.
My dream was to play for him. Problem is, I'm 6 foot. I do not have John Stockton hands. I can't jump like Michael Jordan. I can't shoot like Steph Curry. So the dream job, my wife always tells me, I'm a basketball junkie.
Okay.
And I'll be sitting there going, oh, wow, did you see that back pick? That back pick sprung them free. Then all of a sudden you'll see Jay Billis. Let me show you how this back pick set by. And she's like, just go to ESPN. Just shut up.
Who is your role model?
Multiple. And I had a good mom and dad.
Yeah.
I have a great brother, older brother, who's a role model, right? Externally, role models. Growing up, I had an incredible pastor, and he was the most open, forgiving, welcoming, loving. Here we are in 1983, and there was a staff member who was homosexual in a Southern Baptist church in Little North Carolina. I don't want to say who, what, or what. I mean, who knows where's that now? But he didn't care.
Yeah.
Of course. Hey, you want to come on in? You want to get a little closer to God?
Yeah.
People think it's a sin. Welcome. Join the club. Come on in. He's still alive. Pastor Fred Thompson.
If you had a TV show about your life, what actor would play you?
I don't know, but every time I watch Friends, Chandler Bing, I'm like, oh my God, I would have said that. Oh, dude, that's totally me. Oh, that smart ass comment. That's me. And my wife's like, that's you. You're Chandler Bing.
Nice.
So it'd be a Friends reboot in a movie with Matthew Perry playing it.
Nice. What's the worst advice you've ever received, and what would be a good advice that you would give?
I took a job out of college in 92. A friend of mine was like, why don't you apply for this job? I'll work at the company. I was miserable for 2 years, living where I lived and working where I worked. A friend of mine still is in my wedding, still a great friend, right? And when I moved to Charleston to go to MUSC and go to class at night, I felt like I had died and gone to heaven. But I promised my buddy, if I came there, I wasn't going to quit immediately.
Yeah.
Right.
Makes him look bad.
Yeah. What's something in your industry that you consider underrated?
Hospice care. My dad died when I was 95. He was 55, one day before his 56th birthday. He had a rare dementia disease.
Wow.
I was a teenager and he was dying, just didn't know it. I could just tell his behaviors were changing. He died in a hospital bed, surrounded by white walls, a bed, and nothing. I wish hospice would have been a known quantity. It is so beneficial. We utilized it when my wife's father passed away in 2019 from Alzheimer's. The experience between that and my dad is completely different.
What's one thing outside of what you already do that you'd love to be an expert at?
And when I was 20, the snot-nosed kid got really humbled, studying abroad in Paris, France. I did a 3-day trip up to Normandy, and I spent 2 days on the shores of Omaha Beach. And I met an original first shift, first wave D-Day veteran. Wow. About 70% died.
Wow.
And me and a buddy were eavesdropping on he and his family. The guy had never been back. He's sitting there shaking and crying.
Wow.
And he looked at me. I looked at the guy. I said, I'm so sorry. This is a personal moment, and I'm eavesdropping on you and your family. My apologies. He goes, your generation needs to know about this. And I listened to him. I couldn't look at my buddy because we're 20. We're trying to be cool. We're both crying. I'm not crying. Are you? No.
Yeah.
Wow.
And I've become a war history buff, especially World War II. And boy, I'd love to be able to take a couple more classes and go audit a class at Winthrop on it, learn more from somebody with an actual doctorate who studied and researched it.
The last one, history related, I guess, potentially. If you could meet anyone, past or present, who would it be?
George Washington.
Oh, yeah.
Oh, a good one.
Back to history.
Back to history.
Back to history and war and all that.
Yeah, so really,
what would you ask
when
George?
This Constitution was made, what was the thought behind this? And what was the thought about, this amendment?
Tell me what you think about the Second Amendment.
Yeah. I mean, because, the original version of it actually said you can carry your gun on your property, right? And that's all.
Yeah.
Right? Huh. And then somebody said, wait a minute, what happens if we have to go to another war?
Yeah.
And they need to cross somebody else's property to get to the group, right?
Yeah.
So then they said, all right, you know what the first part of the Second Amendment says?
Preserve a well-regulated militia.
Militia.
Yeah.
That's with intent.
Yeah.
So I'd like to know what that intent is.
Right.
Where was that Louisville Shooters militia that had the AR-47?
Right.
Where was this? I have 3 guns in my house. People forget about the first part, which is the most important part. That's not healthcare related. and I'll probably
It
get
kind
hate
of
mail.
is.
Okay.
I'll probably get hate email. I'm not saying a position. I just
Hey.
want to know what they were thinking.
Yeah.
Oh, yeah.
You know?
No. Well, thank you so much for joining us. It's been truly a pleasure.
Yeah, it's
Yes.
been great. I'm sorry you're going to have to edit the hell out of this thing to get it down to a workable time frame.
We'll just break it up
No.
into like 3 episodes if we need to.
Yeah.
It's been a pleasure.
All right.
Any final thoughts? Anything else that you haven't covered?
Oh, wow. There's so much more to talk about in healthcare
Yeah.
and in higher education. I hope people in this community appreciate the economic impact that the university has. I think it gets overlooked.
Mm.
And the talent impact
Yeah.
it has, I think it gets overlooked.
Mhm.
Hopefully there'll be more connection
Yeah.
between the university, businesses, cultural events,
Mhm.
community events.
Yeah. Well, hey, it's been a pleasure. Thank you so much for sticking around and listen to us. Stick around next week and see what we talk about on the Bandit Room.
The Bandit Room is a production of Span Enterprises, located in sunny Rock Hill, South Carolina. We've been developing, supporting, and growing successful IRS e-filing and business management solutions since 2010. Go to spanenterprises.com now to learn more. The views and opinions expressed in the Bandit Room are those of the guests and do not necessarily reflect or state the opinions of Span Enterprises. No information should be considered as tax, legal, or other professional advice.